welcome both of you to the studio.
Thank you very much.
So let me start with you, John, and tell us a little bit about where we're heading in the area of myocardial perfusion imaging with respect to application clinically with consequent or subsequent reduction in the radiation exposure to patients.
Right, so radiation exposure obviously has come to a head in terms of the importance of it and trying to limit radiation exposure in our patients who get imaged. And there are many layers to how we can potentially reduce radiation exposure. One, of course, right off the bat is appropriate use criteria. And obviously, if someone is imaged for an inappropriate reason, then whatever radiation they receive is also inappropriate. So the first line in terms of screening patients is to make sure that a patient who is imaged is done in an appropriate fashion. The next level is once you have an appropriate patient, what are the best techniques that can be used to limit radiation to that patient? There are many procedural things that can be done without the need for new software or hardware, just in terms of what you do in the laboratory.
Yeah, tell us about the areas that you've been working in that regard.
So there are many ways to image patients, and for years we have really done stress rest imaging protocols in our patients with the idea that if someone had a normal stress study, then they would not have to go for rest imaging. So they would get a low-dose stress image at 10 millicuries of technetium, and then, only then, if their study was questionable or abnormal, would they get a higher technetium dose.
For the rest image.
Exactly, for the rest image. And with this kind of procedure, you can significantly reduce radiation exposure. This is seen in approximately, within any given laboratory, 50 to 60% of patients might be eligible for stress-only imaging.
Right. And tell us now about some of the advances that you referred to in software and hardware that also yield, high sensitivity images but a low radiation dose.
All of the software vendors and all the major vendors have iterative reconstruction techniques that are available, which use resolution recovery and noise reduction in an attempt to improve count statistics. And it's clear that you can reduce counts by anywhere from 50 to 75% with the use of these new software packages. And so you could reduce dose by a comparable amount and still get the same kind of imaging. And there's been many different software validations done with wide beam reconstruction, as well as with other different iterative techniques to do half-time imaging and even half-dose imaging, and have gotten very similar results in terms of image quality. So these are techniques that are relatively easy to do on existing cameras where it just requires a software fix.
Just to follow up, with a 10 millicurie stress-only dose, what would be the radiation exposure to patient? How low can we get?
Right. So I can tell you in our particular publication, those patients who had stress-only imaging received less than 5 millisieverts of radiation in over 60%. And if you look at a 10 millicurie dose, you're talking about a 2.5 millisievert dose of radiation.
John, I'm going to get back to you on the use of PET imaging and where that is heading, and also the whole area of patient-centered imaging. But I'm now going to turn to Dr. Travin, to Mark. We've been talking mainly about patients with chest pain, stable coronary syndromes with respect to perfusion imaging. Tell us where we're heading in the direction of heart failure imaging, imaging of the sympathetic nervous system with respect to current progress. Where do you see this heading?
Well, as we know, the underlying basis of much cardiac disease is molecular, and heart failure is a disease where a lot of the pathophysiology is related to molecular processes, so therefore quite ideal for a radionuclide agent to be able to image. And the area of focus that I've been interested in is imaging the autonomic innervation of the heart. Autonomic innervation of the heart is extremely important. It allows us to adjust our heart rate and stroke volume, for example, under normal circumstances. And the setting of disease, particularly heart failure, the autonomic nervous system is disrupted. And with a radio tracer, something called I-123, iodine-123 meta-iodobenzoguanidine, a norepinephrine analog.
This is MIBG.
Correct, MIBG are the initials. It's an agent we can image with SPECT imaging because it's I-123, and it allows us to assess the presence, the anatomic presence, and the function of the sympathetic innervation of the heart. It's been under investigation for many years, developed approximately in the 1980s in Michigan, and some early studies in the early 1990s from single centers showed that it was particularly powerful in risk stratifying patients with advanced heart failure. Basically, you would image the uptake in the myocardium, the heart uptake, and you would reference it to the background, the mediastinum, generate what's called a heart-mediastinal ratio. And it was seen that this measurement was extremely powerful in terms of risk stratification, number one. Number two, in multivariate logistic regression analysis, it was consistently shown in many small trials to be prognostically superior to heart size and to ejection fraction.
That means the lower the ratio, the worse the prognosis,
That's
right?
correct. So for many years, there were small studies that were published, but more recently, people wanted to do larger prospective trials with the thought being not only could you use this technique to risk stratify patients, but perhaps more importantly, to actually guide management.
Risk stratify for who might be at risk for sudden death, for example?
Sudden death, for example. Why sudden death would be important as a risk stratification in that there's a therapy that has become accepted to address this in primary prevention, and that's an implantable defibrillator.
Right.
And based on recent multi-center trials for that, the current Class 2A indications for a defibrillator are patients with a low ejection fraction and advanced heart failure, Class 2 to 3 New York Heart Association heart failure. But if you look carefully at the results of these trials, it can be seen that a lot of people who get these defibrillators actually don't use them. And in fact, in the SCUD-HEF trial, there was a need to put in 14 defibrillators for everyone that used it. And given this is an expensive technique, we need better ways to decide who needs defibrillators. And the thought was that a technique such as this, imaging autonomic innervation of the heart, which is closer to the underlying mechanism of arrhythmias, would be more effective than the currently used techniques for
Now, you've been involved, obviously, with a major multi-center trial looking at the value of this. In the time we have, can you just give us a little summary about the ADMIRE-HF trial, which really looked at this hypothesis?
Yes. The trial was published in JACC about 2 years ago, and it involved approximately 1,000 patients in 100 sites, U.S., Europe, and Canada. It confirmed what the smaller studies had shown, that in terms of composite endpoints of heart failure, arrhythmic events, and death, that the heart-mediastinal ratio was extremely powerful in risk stratifying patients, number one. Number two, in multivariate analysis, where ejection fraction was entered, and BMP, that the heart-mediastinal ratio was an independent predictive variable in terms of outcomes. And then finally, the negative predictive value of a heart-mediastinal ratio larger than the cutoff point, which was 1.6. The event rate was less than 1% per year of deaths.
Just briefly for our audience, the actual approval of using MIBG for heart failure for risk stratification, where are we with that? I guess you have to have FDA approval or...
I-123 MIBG is approved in the United States, but it's approved for pheochromocytomas and neuroblastomas. It is not yet approved for cardiac indications. And so that's what the FDA initiative is, to get it approved for cardiac indications. It's going through that process. Application was submitted, my understanding, in January, and we should hear over the summer. And we've actually obtained additional data from other sites, including in Japan, which the FDA said they would accept, that has similar results to the ADMIRE-HF trial, further supporting the validity of the results.
So the bottom line, these studies are positive for identifying the highest risk patients as far as added value to conventional clinical variables, ejection fraction, but the MIBG ratio seems to have supplemental value in identifying high risk by ROC curve, if I recall.
Right, or the low-risk patients.
And the
ones that don't need the defibrillator.
Okay.
That's the group we're interested in.
Okay. Let me move back. We're talking about heart failure. We know that PET FDG for viability has been around for a while. But for PET for perfusion imaging has seen a lot of interest lately. And what are some of the advantages and where we're heading with PET?
Right. So one of the issues with PET is that, at least in patients who are very large, BMIs over 25 to 30, there may be some advantage of PET over SPECT in terms of being able to do an initial study using accurate attenuation correction where you may not need to do a rest study if the stress study is normal. So that is another way in which stress-only imaging can be applied, and using a very low amount of radiation, just 1 to 2 millisieverts, if you think about rubidium. I also want to emphasize, though, that even with SPECT, in our particular study, a third of our patients had BMIs over 30. and still only had stress-only imaging. And that's with the use of attenuation correction using SPECT techniques, so that can also be achieved. There are other new PET agents that are in development at the current time, new F-18 agents. Fluoropyridaz is one of them. And this agent is very exciting, I believe, because it has linear extraction across all blood flows, so you don't get the rollover that you see with technetium-based agents and most of the other radiotracers. And therefore, it may have better diagnostic accuracy than what we see with our SPECT agents. And it may also afford better quantification of flow. Lastly, it can be used with exercise, which is one of the advantages of this particular agent over current PET agents.
Yeah, that's very important, I think. So it sounds to me from just the areas that we touched on today that nuclear cardiology is not dormant. It's moving forward despite emergence of other new technologies. And I think the goal of high-quality imaging but reducing radiation is very important. And I thank both of you for sharing your thoughts with us in the studio today.
Thank you very much.